Tonometry is the measurement of intraocular pressure. It is performed as part of the 8-part eye examination to help detect ocular hypertension, glaucoma, and to diagnose ocular hypotony in conditions such as iritis, retinal detachment, postoperative wound leaks, and occult perforations of the globe. Intraocular pressure is measured in millimeters of mercury, and the normal intraocular pressure is between 10 to 21 millimeters mercury. Good day, sir. I'm Dr. Villaruel, and I'm here to perform digital tonometry today. Please remove your eyeglasses. So I'll just instruct you to please look down and make sure not to close your eyes as I do the examination. So please look down, sir. I will just place my four fingers on the superior aspect of your eye. Thank you, sir. A normotensive eye approximates the tone of that of the tip of the nose. An eye with an elevated pressure approximates the tone of the glabella, and the hypotensive eye is similar in tone to that of the lips. The most common types of tonometry are impression or Schiot's tonometry, electronic indentation tonometry, applanation Goldman tonometry, which requires the use of slit lamp, non-contact air puff tonometry for people who had LASIK surgery, dynamic contour tonometry, and Perkins tonometer.
You must prepare and calibrate the Tonopen device before use. Remove the Tonopen from its case and spray the probe tip with compressed gas to clean the mechanism and ensure its free movement. Place a latex cover over the probe tip. The cover should fit snugly but be free of tension. The Tonopen should be calibrated daily before use. Hold the probe vertically with the tip pointing straight down. Press and release the activation switch twice in rapid succession. Two beeps will sound, and CAL will appear on the LCD screen. Hold the probe in this position until a beep sounds. This may take up to 20 seconds. Up will then appear on the LCD screen. Immediately turn the probe 180 degrees so the tip is pointing straight up. In a few seconds, you will hear another beep. If the LCD reads good, the calibration was successful and you are ready to use the device. If LCD reads bad, the calibration was unsuccessful and you will need to repeat the calibration process. If further attempts at calibration are unsuccessful, loosen the latex cover and repeat the process. If repeated attempts are unsuccessful, press the reset button and repeat the calibration sequence. You may also try cleaning the probe tip with compressed air or replacing the battery if calibration is unsuccessful. The patient may be positioned seated or supine during the measurement of the intraocular pressure provided the device is applied perpendicular to the corneal surface. Instruct the patient to look upward and place 2 drops of ophthalmic anesthetic into the lower ocular sulcus. Ask the patient to close his eye to prevent the anesthetic from leaking out of the orbit. Press and release the activation switch once to turn the tonopen on. A beep will sound and 2 rows of bars will appear on the LCD. If the LCD screen remains blank, press and release the activation switch again. Hold the tonopen like a pencil, perpendicular to the cornea. Rest the heel of the hand against the patient's cheek to provide stability. Quickly and lightly touch the cornea at least 4 times until 4 valid readings are obtained. A click will sound and a reading will appear on the LCD each time a valid reading is obtained. After 4 valid readings, a final beep will sound and the average measurement will appear on the LCD. The number on the screen represents the intraocular pressure in millimeters of mercury. The bar reflects the statistical reliability of the reading. A reading above 20% indicates an unreliable measurement and mandates retesting. If four dashes appear on the LCD after the final beep, too few valid readings were obtained. In this situation, reactivate the probe and repeat the measurement. Recalibration is not required.
Goldman applanation tonometry is the most accurate method of measuring intraocular pressure. This test measures fluid pressure in your eye. The test involves using a slit lamp equipped with forehead and chin support and a tiny flat-tipped cone that gently comes into contact with your cornea. The test measures the amount of force needed to temporarily flatten a part of your cornea. Insert the clean tonometer tip in the biprism holder. The 180-degree marking on the tonometer tip should be aligned with the white light on the biprism holder. Instill a topical anesthetic drop and fluorescein dye into each of the patient's eye. Sit the patient at the slit lamp with the patient's forehead firmly against the headrest and chin comfortably with the chin rest. The patient's eye should be aligned with the back band on the headrest column. Instruct the patient to look straight ahead and to open the eyelids wide. The examiner should be seated facing the patient behind the slit lamp ocular. Position the cobalt filter in front of the slit lamp illumination device. The cobalt blue light causes the fluorescent dye on the patient's eye to fluoresce a bright yellow-green. Set the magnification of the slit lamp at low power, with the light beam at high intensity and shining on the tonometer tip at wide angle about 60 degrees. To align the tonometer tip with the patient's right cornea. Adjust the numbers on the tonometer force adjustment knob to read anywhere between 1 and 2, 10 and 20 mm mercury. Instruct the patient to focus on your right ear. Blink once to spread the fluorescent dye, and then try to avoid blinking. Using the slit lamp control handle, gently move the biprism forward until it just touches the cornea. Looking through the slit lamp oculars, confirm that the biprism has just touched the cornea. The spot of fluorescence will break into two semicircles, one above and one below a horizontal line. Raise and lower the slit lamp biomicroscope with a control handle until the semicircles are equal in size. The semicircles can be viewed monocularly through only one of the slit lamp's oculars. In most slit lamps, the semicircles are viewed through the left ocular. If the semicircles are separated, as in figure 1b, the pressure reading will be too low. If the semicircles overlap, as in figure 1c, the pressure reading will be too high. If there is too much fluorescence, or if the examiner is applying pressure to the globe while holding the patient's eye open, the semicircles will appear thick and inaccurate pressure reading will result. With the slit lamp control handle, pull the tonometer biprism away from the patient's eye. Note the reading on the number dial of the force adjustment knob. Multiply the number by 10 to obtain the intraocular pressure in millimeter mercury, and record the pressure in patient's chart. Repeat this procedure to the other eye.
CU's tonometry is a simple, relatively inexpensive, easy portable, handheld instrument. It can be used in any clinic or emergency room setting, at a hospital bedside, or in the operating room, but it requires greater expertise. It uses preset weights that provide a discontinuous scale of measurements. This is an example of Sayot's tonometer. In this illustration, we can see the different parts of Sayot's tonometer. A curved metal footplate is designed for the placement upon the patient's cornea. Then a metal plunger moves up and down inside the cylinder and rests upon the patient's cornea in the center of the footplate. The instrument's frame, or the holder, is held between the examiner's thumb and the forefinger by the handles. In the tonometer plunger, a variety of weights are available to place upon. This is to provide the indentation force, which starts with 5.5 grams of weight. On the tip of the instrument, there's a number scale that shows the measurement of the indentation by way of an indicator needle, which is moved by a hammer in response to the amount of corneal indentation produced by the weight. The scale reading on the instrument must be converted to millimeter mercury using a printed Syot's conversion table. If the needle points in the lower scale, the patient has a higher intraocular pressure. Then, vice versa, if the needle points in the higher scale, it means the patient has a lower IOP. Before doing the procedure, we wash our hands and the instrument. We have to ask the patient to be in a supine position. Then, we have to put a local anesthetics. We have to check the tonometer if it's working. Ask the patient to look straight. Ask the patient to be still and calm. Using the index and the thumb, we can open the upper and the lower eyelid. Then we put the foot plate in the center of the cornea. We can do this 2 to 3 times to ensure we are getting the correct measurement. In here, the examiner tried to put a 10-gram weight on the plunger of the tonometer. Then checks again the left eye by putting the foot plate on the cornea. Try to look the examiner's hands as he do it 2 to 3 times to measure it accurately. Now on the right eye, just make sure that the instrument is always on the vertical position and try to notice that the needle of the instrument is pointing at the 11th scale of the tonometer. This is a conversion table. For the first column will be the representation of the scale reading of the tonometer. For the second up to the last column will be the conversion or the converted measurement of each weight. The patient has an 11 scale reading measurement that use a 10-gram weights and it's converted to 13.8 means the patient is in normal range.
The air puff test, or more correctly the non-contact tonometry, works by shooting concentrated air into the cornea, and the machine observes how the cornea rebounds from this puff. If the eye has a low pressure, then the cornea will flatten quite a lot. But in an eye with high pressure, on the other hand, it will not flatten as much. Think of it like inflating a balloon. The more pressure there is inside, the harder it is to press onto it. It is the difference in rigidity that allows us to measure the pressure in the eye. This is a non-contact tonometry at rest. Align the patient's lateral canthus with this mark. Air puff is released through this aperture for the measurement of intraocular pressure. Patient is asked to focus on the green light seen through this aperture. We'll start by first explaining the procedure to the patient. Sir, kindly place your chin here and please look straight. Focus on the green light inside. You will feel puff of air hit your eye. Do not blink or move your eyes. You will not feel any pain. Use the buttons on the control panel and joystick to focus. Focus on the center of the patient's cornea of the right eye. Air puff will be released automatically when the focus is right. Similarly, focus the left eye. The message "Finish" appears on the screen, indicating that the measurement has been taken.